Before further ado, our first speaker is Dr. Lai. Dr. Lai obtained a PhD in genetics at UBC and the MD at the University of Toronto. Before completing his internal medicine residency, hematology and thrombosis fellowship at UBC. Currently, he works as a staff hematologist at Vancouver General Hospital and clinical assistant professor at UBC. Dr. Lai, take it away. Thank you.
So thank you for that kind introduction. I hope everybody can hear me okay still. And it's a pleasure to be at this symposium. I just want to quickly thank the organizers of this wonderful event. I remember still sitting at the training in the seats there, and it's just a wonderful learning experience over here. The topic of my talk today is antiphospholipid syndrome, or APS, and it's a huge topic. It's something that I can spend hours talking about. And I've been allotted about half an hour, so I've chosen instead to talk about just the latest understanding of the pathophysiology of this disease and where we might be going with that in terms of treatment beyond antithrombotics. So, how come my slides are not advanced? There we go. So I'm going to start with a case. So this is a 63-year-old gentleman that I've seen in my clinic. And he comes in with recurrent small vessel thrombosis. So this all began in 2020. Came in with this pretty ugly looking rash on his leg. You can see parts of it look necrotic, parts of it look lipidoid, parts of it look vasculitic. There's bullae, there's toes that look a little bit ischemic. And he was scanned and he was investigated by multiple services. He did not have any macrovascular clots, so he didn't have a DVT. He had some arterial disease, but upon further investigation, they were not thought to contribute to this presentation. And then he was found to have APS antibodies. His story is actually quite complex. I'm going to focus on the APS part of the story today. He had positive anticardiolipin IgM and positive anti-beta-2 glycoprotein 1 IgM as well. And this was repeated, and it was positive, multiple months, multiple iterations. Moreover, when his skin was biopsied, at first we were thinking this looks vasculitic, maybe it's some kind of rheumatic disease. But interestingly, what it showed was these blood clots that were forming in the small vessels, in the capillaries of the skin. And there was actually no evidence of leukocytoclastic vasculitis. Now, he was treated with anticoagulants, with warfarin. There's a clot, I'm going to treat it with anticoagulant. But what's interesting is that he kept having recurrences. So these are painful lesions that took months to heal. And now imagine him dealing with this on every 6-month basis. They kept coming back every about 6 months or so. And when he had recurrences, his INR was actually therapeutic or even super therapeutic. So it was fairly clear after a while that antithrombotics was not enough to control his disease. I'm going to back up a little bit and just bring everybody to the same page. When I say APS and antiphospholipid syndrome, we often use the Sydney criteria to define this disease. It was originally published in 2006, but originally meant for research purposes, but co-opted into the clinical setting quite a lot. And it stipulates that patients must have both a clinical criteria and a lab criteria. And the clinical criteria is either thrombosis, like our gentleman, or obstetrical problems, so recurrent miscarriages, preeclampsia, eclampsia, or placental insufficiency. There are also lab criteria, so anticardiolipin, anti-beta-2 glycoprotein 1, or this functional assay, lupus anticoagulant. And you have to have positivity at least twice, 12 weeks apart, of the same lab criteria. So this has been in wide use for the last 16, 17 years or so. But since then, there's been a lot of publications that have come out to show that there are other antibodies that have been implicated in the mechanism, the pathophysiology of APS. And also, there are extra criteria clinical manifestations beyond thrombosis and obstetrical problems. So in neurology, there are findings, there's this enrichment of unexplained seizures, movement disorders, thrombocytopenia, lipido, sort of vasculitic looking rash, pulmonary hypertension without the presence of clots, cardiac vegetation disease, merantic endocarditis, proteinuria, and nephropathy that's unexplained. So all of these have all been linked one way or another to APS as well. So it's truly a sort of multi-organ disease. Now, the treatment for APS so far has been largely antithrombotics. I mean, it makes sense for patients who present with thrombosis. Even in obstetrical APS, patients are treated, they start aspirin preconception, and they receive low molecular weight heparin during their pregnancy. And that has been shown to increase the live birth rate. So that seems to work as well. For non-criteria manifestations, as I mentioned, these are the cardiac valve disease, the skin ulcers. Antithrombotics have been used, but by and by, if you look at literature, they don't seem to work that well. And this is where we start to see the introduction of immunosuppressives. The APS Action Registry recently published their data showing that 14% of APS patients who do not have another disease of an autoimmune disorder have been treated to some degree at some point with immunosuppression in their registry. And then finally, the most severe form of APS, this entity of catastrophic APS, this is when they have accelerated development of multi-organ kind of involvement and failure. So they might come in with stroke, then they get a PE, and then they get these skin ulcers, all in the short span of about a week. These patients do poorly. They have a mortality rate of about 40%, and we give them antithrombotics, but we also just throw the kitchen sink at them. You know, they get high-dose steroids, they get plasmapheresis, IVIG, CD20 inhibition, C5 inhibition, and yet they still do sort of poorly. So there must be a way to rationally use these immunosuppressives to improve patient outcomes, and that's sort of the holy grail and the sort of focus of today's presentation. But to achieve that, I think what we need is a better understanding of the underlying pathophysiology of APS. Now, this is a wonderful graphic that was in one of the review articles published this year. And I've just added on this left side, this left panel here to remind everybody that this is autoreactive or an autoantibody disease, which means there must be autoreactive B cells that have lost tolerance. So we'll talk a little bit about this near the end of the presentation, some interesting data coming out for B cell biology in APS. But these antibodies, they bind targets such as beta-2 glycoprotein 1, and this entire complex can bind to endothelial surface or to platelets, neutrophils, and monocytes. And it activates all those cells, causing them, for example, the endothelium to proliferate, leading to vasculopathy, or activating neutrophils and monocytes to produce cytokines, pro-inflammatory type 1 cytokines, or causing platelet aggregation. And I'm going to tell you three stories. As I said, one of the stories is going to be on B cell biology, but the other two stories is quickly I'm going to touch on the NETosis story, as well as the complement activation story. So, NETosis stands for neutrophil extracellular trap, and many of you may be familiar with this, especially in the basic science world. We've known about this for some 10, 15, maybe longer number of years, and it's increasingly recognized that this is dysregulated in multiple disease states, not just in diseases of hemostasis and thrombosis, but they're finding this in ARDS, in ILD, in many, many human diseases. In this process, neutrophils that are activated or dying, they extrude their DNA. And their DNA is loaded with these histone proteins, as well as coagulation factors, factor 12, factor 11, tissue factors. So it's this very sticky material that binds and hangs on to platelets and RBCs. And it's the perfect scaffold to bring all of these protein factors and cells together to propagate clot. And in diseases such as heparin-induced thrombocytopenia, this is hijacked and is upregulated. So in APS, this seems to be the case as well. And now you'll notice that throughout my presentation, I'm going to show you some preclinical data first, mostly in the mouse world. And then I'm going to show you some human data, and then we'll talk about where we're going in terms of treatment. So this is the preclinical data for NETosis in APS. These are mouse neutrophils. I hope the blue is coming through here. The mouse neutrophils have been stained using immunofluorescence in blue for DNA, and then in green for citrullinylated H3. It's one of the histone proteins, a marker of NETosis. On the left, these neutrophils have been incubated with control IgG, and on the right, these mouse neutrophils have been incubated with APS patient isolated IgG. And you can see this increased signal of these extruded DNA material loaded with citrullinated H3, suggesting that NETosis is being upregulated if you treat these cells with APS antibodies. Now, what these are, this is actually a section of a blood clot. So these are taken from mouse models where they induce thrombus using an injury model in the IVC. And they simply dissected out the clot, sectioned it, and then stained it with H&E, or for DNA using immunofluorescence, or for citrullinated H3 using immunohistochemistry. Now, they pre-infuse the mice with APS patient serum or control serum. And the first thing you'll notice is the blood clot that's isolated from APS serum treated mice is longer. This is, the legend is here. This is 1 millimeter. It's longer than mice that's been infused with control serum. Secondly, they're seeing an increased signal in DNA as well as citrullinated H3, which overlaps. And then if they map it per surface area, there is that increased signal in mice that's been infused with APS serum of citrullinated H3, suggesting again that there's NETosis, that it's being upregulated, and it's concentrating in these blood clots. And this has been studied to some degree in human as well. So these are now human neutrophils incubated with control serum or APS serum. And they're staining here for DNA in blue and neutrophil elastase, which is another marker of NETosis, in green. And you can see that if the neutrophils are incubated with APS antibodies, they seem to have these extrusion kind of signals. And this is just one representative patient, but they did this multiple times. And the percent of nets per neutrophil does seem to be increased using APS patient serum. So how do we target this mechanism? Well, not a lot of work has gone into this direction for various reasons. But this publication that came out a couple of years ago did show that an old drug, so dipyridamole, seems to be able to downregulate NETosis. But what we have to keep in mind is that dipyridamole has many actions, and it's not only an antiplatelet itself, it also has vasodilatory effects. It's a PDE inhibitor. And on top of this, it seems to downregulate NETosis. Now, in this mouse model, again, this is one of those models where they induced a thrombus in the mouse IVC, dissected out the thrombus, looked at the size of the thrombus. These mice were treated with APS serum. If you also gave the mice dipyridamole, then you see this decrease in thrombus length. And you might wonder, well, maybe it's just the antiplatelet effects, but they also stained it for MPO DNA complex, a marker of NETosis, and they showed this decrease as well. That's really as far as anybody has taken it. This data is published in 2019. And I, for one, have not seen a specific drug that targets NETosis that have been studied well for any disease for that matter. But there are these other drugs, old drugs like dipyridamole, even some data behind aspirin to show that there's multiple effects, including NETosis, in these old drugs that may have been harnessed. And maybe that's why, using aspirin in APS for its anti-thrombotic effects, you're also getting this beneficial effect from inhibition of NETosis. Now I'm going to segue into complement activation, because complement activation has been shown to induce NETosis as one of its end results as well. Now, complements, as many of you know, is this cascade that begins with the classical pathway, lectin pathway, or alternative pathway. And it results in the activation of the C3 convertase, cleaving C3 to C3a, C3b. And then that complexes with other factors to create the C5 convertase, which cleaves C5. And the end result of it all is you get this C5b-C9 or C5b9 complex, which is the MAC, the membrane attack complex. It's these pores that are punched into target cells, causing them to lyse. And we've known for some time now, actually, that complement probably plays a role in APS-driven thrombosis. These are some really elegant knockout mouse studies that are, some of them are 15 years old or so. And what they show is, again, using these vessel injury models where they induce thrombus, in mice that have been infused with IgG from healthy serum control or from IgG from APS patients, first of all, notice so black is wild type, white is knockout mouse. So first of all, notice the thrombus size is increased if you infuse the mice with IgG from APS patients. But if you knock out C3 or C5 or C6, you see this decrease in thrombus size in these mouse models, suggesting that that complement activation seems to be a part of thrombus propagation. And then 2 years ago, Chaturvedi et al. Published this exciting paper in Blood, where she showed complement activation using APS antibodies. So how they did this experiment was they had this cell line, this human cell line, that was sensitive to complement-mediated attack, complement activation, I should say. And they cultured these cells with either normal human serum, so control, whereas their positive control, they also treated the cells with sugar toxin. And they're doing this flow cytometry experiment where on the y-axis, it's site scatter, on the x-axis, it's anti-C5b9, that end result of complement activation, the deposition of MAC onto cell surface. So if you treat these cells with sugar toxin, you see this shift into this quadrant. So cells were starting to have these complexes being deposited. If you treat the cells with APS antibodies, so this is antibodies isolated from a patient, you also see this shift of these cells into this quadrant. And this is completely abrogated by anti-C5 antibody that's incubated with the cell line. You have this loss of signal in this quadrant here. So this is flow cytometry, but they also did a cell viability assay. This is the modified HEM assay, where they took the same cell line and they just incubated it with healthy control or APS serum or positive control sugar toxin, and they just measured the percentage of viable cells at the end of their experiment. So you can see in APS serum treated cells, you actually get nearly 100% cell death. But this is completely abrogated again using anti-C5 antibodies. Now, we've known for some time now that in case reports at least, that Eculizumab, one of the C5 antibodies, is being used to treat things like catastrophic APS, but those reports are very far and few in between. So this kind of data was generating a lot of excitement to look at complement a little more closely. Furthermore, Chaturvedi et al., they also showed, they sequenced the complement regulatory genes, so they're listed down here. They sequenced these genes in catastrophic APS, APS, lupus, atypical HUS is their positive control, and healthy donor, healthy control patients. And their numbers are pretty small. For catastrophic APS is a pretty rare disease, and they only collected 10 patients. But there's this hint that the mutation rate of complement regulatory genes seems to be enriched in the catastrophic APS patient cohort compared to the others. And interestingly, in the normal APS cohort, the mutation rate is actually very close to control, suggesting that the difference between APS and tipping into catastrophic APS is the loss of complement cascade activation once you've started a thrombotic kind of process. Since those publications, there has been a few letters to the editor type publications that have kind of put a dampener on things. So in this cohort, this is a cohort of 11 patients, all having catastrophic APS, who have been treated with the C5 inhibitor, Eculizumab. But only about, or less than half of the patients actually responded and got better. The other half did not or died. So we're still missing some piece of the puzzle. This is another publication where the authors looked at APS nephropathy. This is biopsy-proven APS nephropathy. They isolated serum from these patients and then treated cells in culture, I should say, and looked at C5b9 deposition on these cells. They used a different cell line than Chaturvedi's experiment, and they did not see an increase in the C5b9 signal in their APS-treated cells. And this is their positive control. This is the prototypical complementopathy disease, atypical HUS. So again, there's something that we're still missing, and that's where we stand in terms of the complement story right now. And I'm just going to spend the rest of my time, I think about 5 minutes left or so, on the B cell story. And just to kind of bring everybody to the same page, B cells, they derive from hematopoietic stem cells. They come into the B cell lineage. They acquire the CD19, which is one of the first markers they acquire. And they go through a bunch of steps that I'm going to skip. But mature B cells beyond this stage all have this CD20 marker. They lose it in the step where they commit to plasma cells. They lose CD20, but they gain CD38. Now, CD20 inhibition or targeting has been tried in APS. So rituximab is this chimeric monoclonal antibody that has revolutionized B-cell non-Hodgkin's lymphoma treatment. And rheumatologists have been using it for rheumatic diseases, and they've been using it for APS patients as well. Not to a wide scale. So this is a selection of studies, mostly observational, where there's been more than 5 patients reported in one study using rituximab to treat things like non-criteria manifestations, to treat catastrophic APS, even to treat recurrent thrombotic APS. And only one of them is truly prospective. This is a pilot trial at that, so at N of 19. Now, in the first 3, we can probably summarize that the effectiveness is only about 50%. And this last study is very small, and it undoubtedly has some selection bias. So even though it looks like everybody was getting better, and I should add to that, the follow-up period for these 6 patients was not uniform either. I think this data for the recurrent thrombotic APS is actually inconclusive because these patients, first of all, need to be studied for longer and they need a bigger cohort. Now, Erkin et al.'s study also showed this interesting data where rituximab treatment did not completely make the APS antibodies disappear. So they measured lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1 at the beginning of their patient follow-up and after 52 weeks. And interestingly, of the patients that remained where they could measure these titers, a lot of them still had detectable lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1. And why is that? You're depleting B cells, after all, using the CD20 targeting, and yet you can still find these antibodies 52 weeks down the road. And it probably has something to do with this. About 2 years ago, this group in Japan published a study showing that there's plasma cell skewing in APS patients. So this is a flow cytometry experiment where they looked at primary APS patients as well as healthy control. And they simply gated the mononuclear cells for CD19 positive, 38 positive, and 27 positive cells, the ones in this gate. And these are 20 negative cells, CD20 negative cells. So these are basically plasmablasts and plasma cells. And there's this enrichment in primary APS patients compared to healthy control. This is one representative patient, and these are, each dot is a patient here. So they looked at patients with primary APS, they looked at patients with secondary APS, so APS associated with lupus, and they also had healthy control. And their gating here is for memory B cells, down here for plasmablasts. This is their immunophenotype signature that they used. And they show that there's a decrease in memory B cells compared to healthy control, and an increase in plasmablasts compared to healthy control. And if they deplete the plasma cells versus depleting CD20 positive mature B cells, they can actually make the anticardiolipin and the anti-beta-2 glycoprotein 1 antibodies completely disappear. So this is peripheral blood mononuclear cells, and this is just a measurement using optical density of anticardiolipin produced by those B cells. And if they deplete CD20, you do see a decrease in the anticardiolipin titer, but it does not completely disappear. Whereas if they deplete plasma cells, so if they deplete CD20 negative B cells, then they can no longer detect anticardiolipin, and same with anti-beta-2 glycoprotein 1. So this suggests that perhaps we're targeting the wrong B cells. We should really be looking at targeting the plasmablasts and the plasma cells. We've been using rituximab where we should be thinking perhaps about, for example, anti-CD38 antibodies, so daratumumab, or bortezomib, which is a proteasome inhibitor, which plasma cells are exquisitely sensitive to. So there are many publications now calling for trials and clinical studies to use these agents in APS treatment. So near the end, I want to bring us back to this graphic, which is a summary of our current understanding of APS pathophysiology. And I've just labeled here all the agents that have been looked at, some of them in preclinical trials. So dipyridamole, for example, beta-2-GP1, decoy molecules, for example. But some of them are much closer to clinical studies. In fact, there are some randomized control trials currently going on for hydroxychloroquine, for adalimumab, for Eculizumab, and there is quite a lot of chatter about, again, targeting plasma cells as well as targeting BAFF, so using adalimumab. And what happened to my patient? Well, he was found in the end to also have a B-cell non-Hodgkin's lymphoma. He had marginal zone lymphoma. Because of that, he got treated with rituximab, among other things. And this is his skin after about 6 months of treatment. Interestingly, we saw a decrease in the antiphospholipid antibody titers, but they did not completely disappear. And as I showed you that data earlier, it's probably because we haven't killed off all the plasma cells and plasmablasts. But 6 months in, his skin actually looks pretty good. And I think only time will tell if it'll stay this way or if it relapses, if we need to start to think about other strategies to treat this disease. So I'm going to end there. There was a whirlwind tour through the latest pathophysiology of APS. I just want to, again, thank the VGH APS Endowment, as well as the Neiman Vickers Endowment for supporting me in my research endeavors. Thank you. I'm happy to take any questions now.
Thank you so much, Dr. Lai, for the great talk. We can take a few questions from the audience, and if you can please raise your hand if you have any question, and we have a mic runner that they can come to you, that the audience over the virtual can hear you.
Thanks, Ben. That was a fantastic talk. It's Luke here. We sit across from each other every Friday, but it's only at something like Earl Davie that we can really think and talk about these things. So your talk sort of got me thinking about the immune dysregulation in APS. So we focus a lot on the autoimmunity aspects, the antigen-dependent inflammation in APS, but there's also data showing that there's antigen-independent inflammation in APS. So for instance, the phenomenon of SNAP, seronegative APS, where people clinically behave like they have APS, but you can't find any antibodies. Or anecdotal reports of people with severe APS who respond to anakinra, IL-1 blockade. So nothing directed at the auto-antibodies per se, but just anti-inflammatory and with resolution of their auto-antibodies. So I'm wondering about, one, what do you think about the role of auto-inflammatory pathways in APS? And two, I think sometimes we try to be a bit too clever and try and target something very precisely when perhaps that's not the entire culprit. Like, you would think that if it's all about complement, that Eculizumab would work for everyone, or if it's all about auto-antibodies, Ritux would work for everyone. But I wonder, what about something like lenalidomide that would blunt not only the B cells, but also the inflammatory cascade, no matter what's producing it?
Yeah, so those are great points. The seronegative APS, that's a very nebulous entity, and we don't know if it's just because there are just some antibodies that our assays are not good enough to pick up. So, but your point on pro-inflammatory cytokines and their activation, type 1 cytokines, is well taken. And there are actually, at least in obstetrical APS, some efforts nowadays to look at these agents in clinical trial setting for turning off that TNF alpha driven, that type 1 pro-inflammatory cytokine driven kind of disease process. And some way to because a lot of these processes are interconnected. I didn't show you the data, but NETosis is activated by complement activation, for example. So Yeah, I think you're totally right. Like if we just target one thing, just like we're throwing anti-thrombotics at this disease right now, and we're really only addressing this very downstream part of this disease process, things like hydroxychloroquine, which has multiple effects on multiple areas of the pathway. So hydroxychloroquine has been shown to decrease the titers, but it's also been shown to decrease cytokine production, and perhaps that's why it's used so widely in the rheumatology world. Maybe we should be thinking about that for APS treatment. But I think we're still at the very beginning of this, right? People are still throwing, there's anecdotal reports of neurologists throwing warfarin at patients with seizure who are thought to have APS, but they've never had thrombosis before. Now, is that the right thing to do? Who knows? But we really need a good understanding of the pathophysiology, and from that we can make rational decisions on treating this disease.
Ben, it's Ed Conway here. That was great talk. Just to follow up on the complement story, we should just be careful about drawing the conclusion that if you require a membrane attack complex and C5a generation to trigger tissue factor and coagulation, there are upstream mechanisms by which complement can induce tissue factor by monocytes. Upregulation of tissue factor. And so, and actually there's a very nice model presented for HIT by Doug Seens and Gowar-Rapelli, where it's clear that you need proximal interference of the complement cascade to have an effect, whereas Eculizumab wouldn't work in that model. So just for everybody working in this field, because we tend to take home the story, well, if Eculizumab doesn't work, therefore it's not complement. That's clearly not true.
I totally agree. And there's C3 inhibitors coming down the pipeline. There's avacopan coming down the pipeline for ANCA vasculitis. And actually, the avacopan story for vasculitis, they did show, I think in preclinical data, that there was other things going on, like downregulation of NETosis, for example. So yeah, we're again, only at the beginning of understanding this.
Thank you very much. I guess we can get one more question in the audience. All right, if there is no more question, please join me and thank Dr. Lai.